You know, usually when we think about our skin, we picture it as this static canvas, like a surface that just sits there, maybe occasionally getting a little dry or oily.
Oh, right. Yeah.
But if you zoom in, especially around the mouth and the lips, you are definitely not looking at a canvas. You are looking at a highly dynamic, constantly shifting tectonic landscape.
It's basically a biological earthquake zone.
Exactly. Every single time you speak, chew, sip a coffee, or just smile, massive biomechanical forces are just ripping through that tissue.
It's an incredibly violent environment, biologically speaking. I mean, the sheer amount of movement, stretching, friction, it is staggering when you look at it on a microscopic level. It's just a zone of relentless kinetic energy.
And, well, that is exactly where today's deep dive begins. If you were listening to this, you asked us to track down a very specific, almost, detective-like medical mystery.
Yeah, and it's a great one.
It is. We are taking your curiosity and pointing it straight at this fascinating question. Can cross-linked hyaluronic acid filler cause localized tissue induration?
Which is basically medical speak for hard tumor-like nodules.
Right. Can it cause these nodules if it gets deposited just a tiny bit too superficially in the mucosal epithelium, like right near the very surface of the lips?
It's such a brilliant question because it forces us to look at, the intersection of chemistry, anatomy, and honestly, human error.
Yeah, and we have a really comprehensive stack of sources for this deep dive.
We do. We're pulling from the official FDA documentation for Restylane, which is a major hyaluronic acid filler, plus some incredibly gripping dermatological case studies.
Gripping is the right word.
Yeah.
We also have detailed histopathology reports and cutting-edge research on oral wound healing.
It's a lot to get through, but it paints a really clear picture.
It really does. The mission here is to figure out how a substance that literally naturally occurs in our own bodies can suddenly turn into these hard encapsulated bumps just because it was placed like a few millimeters too close to the surface.
Okay.
Let's unpack this. Yeah. Because to understand why things go so wrong in that dynamic moving landscape of the lip, we first have to understand what hyaluronic acid, or HA, actually is in its natural state.
Right, where it's supposed to live.
Exactly. So what are we dealing with here?
So hyaluronic acid is a glycosaminoglycan. It's a major natural component of your body's extracellular matrix.
The extracellular matrix, that's like the stuff between the cells, right?
Yeah, think of it as the biological mortar between your cells.
Mm-hmm.
HA is essentially this massive sugar molecule that is structurally vital because of its hygroscopic nature.
Hygroscopic meaning it loves water.
Precisely. It is incredibly good at holding on to water. In fact, it regulates osmotic pressure in your tissues.
Let's break that down for a second. Osmotic pressure, we're talking about how it balances fluid, right?
Yep.
It acts like a microscopic sponge.
Yep, a sponge that pulls water in to keep the concentration of fluids perfectly balanced across different cell membranes.
That's wild.
It is. That exact mechanism, drawing in water and holding it there, is what keeps your tissues lubricated, hydrated, and resilient. In your skin and your joints, it is basically the ultimate shock absorber.
And here's the crazy paradox I found while digging into this. Natural, uncross-linked HA is actually a healing agent.
Oh, absolutely.
Like in dentistry and oral medicine, doctors use it topically to heal oral wounds, like severe mucositis or those awful Aptis ulcers.
Right, because it promotes cell migration, it triggers angiogenesis, which is, the biological process of building brand new blood vessels, and it actively brings down inflammation.
But the HA in a syringe, the cosmetic filler people get injected into their lips, that is fundamentally
completely different. If a doctor injected natural native HA into your lip to add volume, your body's naturally occurring enzymes would just dissolve it completely in a matter of hours.
It wouldn't even last through the afternoon.
Not a chance. So, to make a cosmetic filler that holds its shape for anywhere from 3 to 12 months, pharmaceutical companies have to chemically alter it.
They ferment it from Streptococcus bacteria, right?
Yes, usually. And then they bind the individual HA molecules together. They cross-link them.
They use a specific chemical for this, right? BDDE.
Yeah, 1,5,4-butynidyl diglycetyl ether.
Right, which sounds like a scary industrial chemical, and it is pretty intense. But the safety data shows that after the reaction is finished, only trace amounts remain in the actual filler, like less than 2 parts per million.
Very tiny amounts, yes. But the presence of that BDDE changes the game entirely. It turns this free-flowing, watery liquid into a dense, cohesive gel.
If we connect this to the bigger picture.
Yeah, if we connect this to the bigger picture, that cross-linking process is what gives the filler its biomechanical strength.
Right.
Imagine natural HA as millions of loose strings of yarn floating in water. BDDE comes in and acts like microscopic rungs on a ladder. It physically ties those loose strings of yarn together into a tight three-dimensional net.
And that net resists degradation.
Exactly. It's fantastic if you want to hold a specific shape in the tissue for a year. But it also sets the stage for severe complications if that dense, stubborn gel ends up in the wrong anatomical layer.
Which brings us to the FDA guidelines for Restylane.
Mm.
When you look at their safety data, they have essentially mapped out the exact millimeter where this substance goes from safe to dangerous.
They're very specific about the depth.
Yeah, it's indicated for mid-to-deep dermal implantation, for facial wrinkles, and specifically for submucosal implantation for lip augmentation, meaning it needs to go deep.
Underneath the mucosa.
Exactly. The FDA even warns that injecting more than 1.5 milliliters per lip per treatment session significantly increases the occurrence of moderate to severe injection site reactions.
Right. The clinical trials demonstrated that when you push past that 1.5 milliliter threshold, or, when you place the filler outside of that deep submucosal layer, the complication rates jump dramatically.
Because you're putting too much in.
You are introducing too much resistant volume into an area that simply cannot accommodate it.
Wait, if HA naturally occurs in our skin, and we even use it as a gel to heal oral cuts, why does our body suddenly have a problem with it just because it's sitting a tiny bit closer to the surface? I mean, why does a distance of a few millimeters make the difference between a plump, natural-looking lip and a hard medical complication?
It comes down to physics and anatomy. The mucosal epithelium of the lip is not just closer to the surface, it is an entirely different mechanical environment.
Right, the kinetic zone we were talking about.
Exactly. We are talking about the area directly overlying the orbicularis oculis muscle. This is the muscle that puckers the lips, allowing you to speak and eat.
So it's constantly moving.
Constantly. When you place a dense cross-linked gel subepithelially, meaning just under that ultra-thin top layer of tissue, you are dropping a static, resistant mass right into that zone of relentless kinetic energy.
I was trying to visualize this while reading the sources, and the best analogy I could think of is like putting a thick dollop of stiff jelly between two sheets of wax paper and then constantly rubbing those sheets together.
That's a great way to picture it.
Right. If you do that all day, eventually that jelly isn't going to stay in a nice, smooth, even layer. The friction is going to push, roll, and compress that jelly into hard, compressed ridges.
And the biomechanics of the lip do exactly that to the filler. The sheer mechanical force of the muscle movement physically dislocates the HA gel.
Because it can't break down quickly.
Right, because it's tightly cross-linked with that BDDE we mentioned. It's highly resistant to being absorbed. It can't dissipate. So instead of integrating smoothly into the tissue, it gets shoved around until it pools into concentrated pockets.
And that answers the core question of this deep dive. Yes, superficial placement in the highly mobile mucosal epithelium absolutely causes localized tissue induration.
There is a totally fascinating and, frankly, slightly terrifying dermatological case study about a pair of twins from a clinic in Zurich that perfectly illustrates this.
Oh man, the twins.
Yeah. They both developed severe lip deformities that the clinicians described as stalactites and stalagmites.
Just picture that for a second. Hard formations hanging down from the upper lip like stalactites in a cave and pointing up from the lower lip like stalagmites.
It's extreme, but it highlights the mechanics perfectly.
It happened because the injector placed the filler way too superficially in this highly mobile region, combined with injecting a bit too much volume at once.
Right.
Over time, the everyday muscle action of them talking and eating literally sculpted the HA gel into these hard, cave-like formations.
And when doctors take surgical biopsies of these superficial lumps, the histological findings are incredibly consistent. Under the microscope, they don't see a nice integrated tissue matrix.
What do they see?
They see pools of what they call amorphous hematoxyphilic material.
What does that actually look like to the researcher?
It basically looks like a massive, unstructured blue blob taking up space where healthy cells should be.
Wow.
Yeah, that blob is the undegraded, cross-linked HA gel. It hasn't become part of the lip. It has just been squished into a localized, isolated pocket, pushing the native tissue out of the way.
And it doesn't just feel weird, it looks weird to the naked eye. We have to talk about the Tyndall effect.
Ah, yes, the Tyndall effect is classic.
Because the HA filler is a clear, transparent gel,
Yeah.
right? If it's placed too superficially, right under that thin mucosal layer, the light entering the skin behaves strangely.
It scatters.
Exactly. The light actually scatters when it hits the clear filler. The shorter blue wavelengths of light bounce back to the surface, creating this unnatural bluish discoloration on the skin. It almost looks like a permanent bruise.
Clinicians look for that blue tint as a dead giveaway of superficial placement, and the physical presence of this displaced gel can cause even more dramatic mechanical issues. In one of the original FDA studies for Restylane lip augmentation, a subject actually developed a mucus cell.
That's essentially a cyst, right?
Correct. It is a mass formation filled with mucus. The superficial filler disrupted the local salivary glands and caused so much physical stress that the body basically walled off the area, creating a mass that actually had to be physically drained by a doctor.
Ouch. But, the physical squishing of the gel by the muscles is really only half the story here.
Right, there's the biological side.
Yeah, the gel gets pooled into these stalagmites by the mechanical friction, but that doesn't fully explain why they get so incredibly hard or why someone can be fine for a year and then suddenly wake up with a rock in their lip.
To understand the hardening, the actual tissue induration, we have to move from physical biomechanics to the biological immune response. We need to explore the mechanism of delayed onset nodules, or DONS.
Dawns are wild to read about. I mean, you get a filler injection, everything looks great, you heal up perfectly, and then weeks, months, or sometimes literally years later, these hard, painful nodules suddenly erupt out of nowhere.
This happens because of a type 5V hypersensitivity reaction. We really need to differentiate this from a type I hypersensitivity, which is your classic immediate allergic reaction.
Like a peanut allergy.
Exactly. If you get stung by a bee or eat a peanut when you have an allergy, your body's IgE antibodies trigger a massive histamine release. Your throat swells up in minutes.
But type 5 isn't like that.
No, type 5 is vastly different. It is not mediated by antibodies. It is mediated by T lymphocytes, specifically CD4 positive T cells. It is a delayed, rumbling cellular response that takes a long time to build up.
So the immune system essentially ignores the filler for a year, and then one random Tuesday, the T cells just wake up and decide this pooled superficial gel is a foreign invader.
Basically, yes. The body eventually recognizes that this dense, cross-linked material is not supposed to be there in that concentrated pool. As the filler very, very slowly degrades over months, it breaks down into low molecular weight fragments.
And those fragments cause trouble.
Because it is pooled superficially, it acts as a chronic, constant irritant to the surrounding tissue. The immune system flags this and sends in the cleanup crew, which are macrophages and foreign body giant cells.
Let's talk about those giant cells for a minute, because the biology here is amazing. What makes a foreign body giant cell, giant?
Well, when regular macrophages arrive at the scene to eat the foreign invader, they realize the pooled HA gel is way too big for a single cell to swallow.
So they team up.
They literally do. Multiple macrophages will fuse their cell bodies together, combining their nuclei and cytoplasm to form a single massive megazord cell, a foreign body giant cell designed to engulf larger targets.
But even fused together, they still can't easily eat or dissolve these dense, chemically cross-linked gel.
They cannot. So they resort to the immune system's backup plan for dealing with indestructible threats, which is quarantine. They build a wall.
Like scar tissue.
Yes. The biopsies of these late-onset nodules show the filler surrounded by a thick wall of densely collagenized connective tissue. The body weaves a tight fibrous scar capsule entirely around the gel. That tightly wound collagen wall is exactly why the nodule feels rock hard to the touch.
Here's where it gets really interesting, though, because sometimes those T cells don't just spontaneously decide to attack the filler. Sometimes there is an invisible culprit pulling the strings, waking the immune system up.
Ah, biofilms.
Biofilms.
Biofilms represent one of the most complex challenges in the study of dermal filler complications. A biofilm is essentially a structured community of bacteria that encases itself in a protective, sticky matrix.
And they get in during the injection?
Often, yes.
Oh.
When the needle punctures the skin to inject the filler, sometimes a microscopic amount of bacteria from the skin's surface, like Staphylococcus aureus, gets dragged down into the tissue along with the gel.
But they don't cause an immediate hot red infection like you normally expect from staph.
Right. No, they go completely dormant. They attach to the cross-linked HA gel, build their little sticky biofilm fortress, and they just sit there quietly metabolizing, sometimes for months or even years.
Just waiting.
But eventually, something triggers them. It could be a minor systemic illness, like a cold, routine dental work that releases bacteria into the bloodstream, or just local physical trauma to the lip. The dormant biofilm suddenly becomes active.
And the immune system notices.
Oh, absolutely. That low-grade chronic bacterial presence kicks the immune system's T cells into absolute overdrive.
And the immune system rushes in to attack the bacteria. But because the bacteria are literally glued to the surface of the filler gets caught in this massive inflammatory crossfire.
Collateral damage.
Right. The giant cells form, the collagen quarantine wall gets built rapidly, and boom, overnight, you have a hard, swollen, painful nodule. When researchers take surgical cultures of some of these intractable, stubborn nodules, they find Staph aureus, Staph epidermidis, and even atypical things like mycobacteria living inside them.
It highlights just how delicate that superficial mucosal environment is. When you place a foreign material, even a highly biocompatible one like HA2 superficially in a mobile, trauma-prone area, you are providing a perfect scaffold for a biofilm to grow and a perfect target for a delayed T-cell reaction.
Okay, so we've established the chain reaction here. Superficial placement causes the physical pooling from muscle movement. That pooling triggers the biological immune quarantine or wakes up a biofilm, resulting in a hard collagen wall.
Exactly.
If this happens to you, are you just stuck with a stalagmite in your lip forever? Thankfully, biology provides an eraser.
A very effective one. Hyaluronidase. It is an enzyme that specifically depolymerizes hyaluronic acid.
It polymerizes. Let's look at the mechanism there.
Remember earlier when we described the cross-linked filler as strings of yarn held together by BDDE rungs like a ladder?
Yeah, the three-dimensional net.
Hyaluronidase acts like a microscopic pair of bolt cutters. It specifically targets and cuts the chemical bonds, the hexosemitic linkages that hold the HA molecules together. It breaks the complex, dense polymer down into simple, harmless sugars that the body's lymphatic system can easily wash away.
The pharmacokinetics of how this enzyme works in the body are completely fascinating to me. It has a half-life of just 2 minutes.
Which is incredibly fast.
Meaning, half of it is cleared from your system almost the moment it gets injected. But its actual duration of action, like how long it keeps dissolving filler, lasts for 24 to 48 hours.
It seems like a contradiction, right? But because hyaluronidase is an enzyme, a catalyst, it requires an infinitesimally small amount to cut those hexosamitic linkages.
A little goes a long way.
Exactly. So even as your body rapidly flushes the enzyme out, the tiny remaining fraction is still doing its job, cascading through the tissue and dismantling the filler network for up to 2 days.
Now, a huge fear I hear people have about this is that if you inject this powerful eraser enzyme, won't it melt your natural HA? Like, will it destroy your natural skin quality permanently?
It is a highly rational concern because hyaluronidase does not discriminate. It will absolutely dissolve your native, natural hyaluronic acid right alongside the synthetic filler.
Yikes.
However, your skin is an incredible nonstop manufacturing plant. The clinical data confirms that your body restores its native HA completely within 15 to 20 hours.
So it bounces right back.
Yes, you experience a temporary dip in natural hydration, but you suffer no long-term detrimental effect to your natural tissue architecture.
You lose a day of natural hydration, but you get rid of the permanent nodule. That's a fair trade. However, it's not always a magic bullet. If you're dealing with one of those delayed onset nodules that has a deeply entrenched biofilm and a massive thick collagen wall around it, just shooting a 2-unit enzyme at it might not penetrate the fortress.
No, in those highly complex cases, especially with chronic inflammation, clinicians often have to attack it from multiple angles.
What else do they use?
They combine the hyaluronidase with specific antibiotics like quinolones or macrolides to kill the active biofilm. They might inject intralesional corticosteroids to aggressively suppress the hyperactive T-cell immune response.
Just throw the kitchen sink at it.
Basically. And in the most severe cases where the collagen capsule is just too thick and conservative treatment completely fails, surgical excision, literally cutting it out, is the final option to remove the hardened mass.
Wow.
This raises an important question, though, which the clinical consensus papers point heavily toward. With hyaluronidase being so effective in standard cases, are we seeing a scenario where practitioners rely on it as a safety net for poor technique?
The idea that having an eraser makes you careless with a pencil.
Precisely. Injecting the mucosal epithelium safely requires a masterful three-dimensional understanding of facial anatomy. If a practitioner assumes they can just dissolve away any mistake, they might be far less precise with their needle depth.
Which leads right back to the problems.
That complacency leads to the exact superficial pooling and biofilm risks we've been discussing.
If you are ever considering this procedure or, trying to understand a complication you've experienced, this is why knowing the exact depth of the injection isn't just cosmetic trivia. It is the literal difference between a natural look and a chronic, multi-year immune battle. It is the difference between hitting the safe, deep submucosal Goldilocks zone and hitting the superficial wax paper zone where everything goes wrong.
The depth dictates every single consequence that follows. The physical mechanics, the blue Tyndall effect, the biofilm risk, the T-cell quarantine response, it all stems from exactly where the tip of the needle starts.
So what does this all mean? Let's bring all these threads together. The initial question was, can cross-linked HA filler cause localized tissue induration if deposited too superficially in the mucosal epithelium? The answer is a resounding, chemically proven yes.
100%.
It happens because the sheer mechanical force of your highly mobile lips physically squishes that stubborn gel into concentrated pools. Your immune system eventually spots this pooled material, or maybe a dormant bacterial biofilm living on it, and launches a delayed T-cell mediated attack.
And then the giant cells move in.
Giant cells try to eat it, they fail, and they wall off the perceived threat with densely collagenized scar tissue, leaving you with a hard, palpable nodule.
But if we step back and look at the trajectory of this entire medical field, there is a broader implication here that isn't fully resolved.
What's that?
The clinical data points out a growing, undeniable trend. Patients are seeking out these HA filler injections at increasingly younger ages, sometimes as young as 16.
Wait, really? 16 years old?
Yes. We have just spent the last 15 minutes detailing how these highly dynamic mucosal tissues react to superficial stress and how the body's T cells respond to the persistent presence and degradation of cross-linked polymers. If an individual begins exposing their immune system to these synthetic pro-inflammatory chains at age 16 and continues getting maintenance injections every year for decades, what is the cumulative, lifelong effect on their localized immune response?
Oh, wow. I hadn't even thought about that.
Are we slowly sensitizing an entire generation's immune systems to constantly fight low-grade inflammation? We are currently in the middle of a massive global biological experiment, and the reality is we won't have the full longitudinal data to know the true cost for another 50 years.
And a staggering thought to leave you with. We started by looking at the lip as a dynamic moving landscape, a place of intense mechanical forces. It turns out it's not just the muscles that are active. It is a microscopic battlefield where modern bioengineering clashes with the immune system's most ancient defense mechanisms. A few millimeters of depth is all it takes to turn a simple cosmetic enhancement into a permanent geological formation. Keep that in mind next time you think of the skin as just a blank canvas. Until next time, keep digging.